Okay, if that will help. Okay, yeah. Yes, it's our time now for the session to start. I take the pleasure to welcome everybody who is on the call already. I know others will be joining as we go on, but I see a couple of us on stretching from, of course, Malawi, headquarters, Ethiopia, Tanzania. I see Kenya. I see International Laboratory Branch, CDC Atlanta, Uganda, and a couple of others, and people continue to switch in. Yeah? Zambia, and a couple of others. I take the pleasure to welcome everybody on this session, which is our September session of our LabCoP Echo session. As you will see, as always, we flash this slide to show the cascade, the viral load cascade, and the system issues that are associated with. And usually what we present is within this framework of the viral load cascade. Just to mention, today we are having a session on a QI intervention, a QI project aimed at improving especially utilization of results. Okay, result utilization is at the terminal end of the cascade, but it is the targeted end. It's all the chain of events that happen aim at a point where we generate results, and eventually results are used to make decisions to improve patient care. So if we do every other thing well, but we fail at the terminal end, it's like all the efforts that we do in this chain of activities are all doomed to nothing. So we must make sure we complete the chain, and by completing the chain, we make sure that the results that are generated, qualitative results that are generated, they are qualitative, they are quality results, and then when they are generated, they are eventually used to make decisions, appropriate decisions for patient care. And this is where many countries are still struggling, and we need to put up systems that make that seamless, make that a flow whereby there is no break in the chain until when the results reach the patient and they are used to judge and to impact the care the patient receives. Every other thing is doomed to nothing. So we are delighted today to have Malawi sharing their lessons. They had a QI project that was targeting this particular terminal end of the cascade. I will ask Dr. Brown to share his slide, to share his screen before I invite him to start. But otherwise, we want to thank Malawi for giving us a chance to learn from their lessons. Nicholas, I think you need to unshare so that, okay, Dr. Brown, you're welcome. Thank you very much, the Malawi team, for allowing all of us on the community to learn from your lessons. And I take the pleasure to hand the floor to the Malawi team. At the end, I will be sharing some news or upcoming events. But for now, let us just get the session to start. Malawi, the floor is yours.
Thank you very much, Dr. Charles. Welcome, LabCoP team members from across Africa. My name is Brown Chiwandira. I am representing the LabCoP country team for Malawi. We will today be sharing with you a quality improvement initiative that we undertook last year, specifically on viral load, working on both ends of improving testing and improving result utilization. This is work that we did last year with some of our partners in one of the districts in the southern region of Malawi, where it's like the epicenter of the epidemic in Malawi. It's a district called Balaka in the southern part of Malawi. So the southern part of Malawi has a relatively higher prevalence of HIV compared to the national prevalence. For example, in Malawi, our national prevalence as of estimates for 2019 is at 8.8%. But in the southern region of Malawi, we have districts that have prevalence of up to 18%. Wow. So here's the outline of the presentation. I'll share with you the approach. As I mentioned, it was a quality improvement initiative or project. I'll share with you the quality challenge that we were specifically working on to improve. What was the quality improvement aim and the indicators, the actual process that was applied, the results, and then what were the successful change interventions that we have harvested, and then the concluding remarks. I must also acknowledge partners that we worked with. So us as a Minister of Health, HIV and AIDS, who were very responsible for technical assistance in this whole quality improvement project. But we had the URC Malawi Lab project as a key stakeholder in this project. Remember, it's a lab clinic interface project. So we're bringing together the lab and the clinic staff to work together to improve issues of viral load monitoring for people on ART in Balaka. We had also the Balaka District Health Office, which is the controlling office for all health issues in this district. And then we had a DREAM molecular lab. So I must mention here that Balaka district is one of the lucky districts in Malawi to have a molecular lab within their district. So we have like 10 molecular labs that are housing about 13 platforms molecular testing in Malawi, and that's where viral testing is happening all across our country. But Balaka is one lucky district to house one of the molecular labs that we have in country. But it's a molecular lab that is manned by an NGO called Community of St. Egidio, also known as DREAM. So proceeding with the presentation, as I mentioned, it was a project form, kind of a code improvement initiative. And it happened between March and September, so it was a 6-month project. We had a few activities that accompanied this rollout, and then we had learning sessions happening every month for the entire 6-month period. So what was the approach that was used in this code improvement initiative? There is what is called model for improvement in quality improvement language. So this is the approach that we used in our QI project. And it was again what is called a quality improvement collaborative, where a couple of facilities came together because they were carrying a common topic area of interest to address, and therefore they had to come up with a common quality challenge, common methods and tools for improvement, plus they were sharing the aim statement, indicators, and measurement processes for this project. So it's a project that was done in 4 high-volume sites in this district of Balaka. In the beginning, for the project to roll out, we had a baseline assessment activity, which included stakeholder consultations to just have a picture of how the problems around viral load monitoring were like in this district. And to roll out the actual project, we didn't like bring in everything new. So we worked with quality improvement teams that are existing in this district per facility level. So quality improvement teams at the district office, and then quality improvement teams at the 4 peripheral facilities that we were working with. And there was a bit of a training, more like an orientation on QI for the quality improvement team members from these participating sites, plus the team from the district health office. And from this training, that's where the quality, as a common quality challenge was agreed upon, moving on with common problem statement, common aim statement, root cause analysis, and even driver diagrams for prioritization were developed from these orientation sessions. Just to share more what the model for improvement entails. So all what was happening was to make sure in the very first place we had defined what improvement aim were we going to chase in this code improvement project, and what measurement methods were we going to track along the 6 months journey. And then we, along the way, teams were expected to be devising like proposed solutions, which we're calling changes, to help them to achieve the aim they were aiming to achieve at the end of everything. So in a nutshell, when we talk of model for improvement in code improvement, it's where the PDSA cycle is brought to use much. So people have to plan, then do their plan, study how their plan is coming out, and then act if there are areas to act upon how their plan has been implemented. So the core challenge that this code improvement project was working with was on, as I mentioned, both on the testing end and the result utilization end. So, for example, our guidelines, HIV treatment guidelines for Malawi, they have listed to say routine viral testing should be a standard measure for assessing clients that are on ART. So every person on ART has to have this right to get a routine test periodically. And then it's clients that are reporting back with a high viral result are supposed to be enrolled in the intensive adherence counseling module, just to have them supported on issues of adherence to make sure they get to get to a level where they can be classified as being stable and doing fine on treatment. But what was happening in the four high volume districts in this district of Balaka was far below what the guidelines entail. So we found out from the baseline assessment that only 61% of clients on ART in these 4 high volume sites had their routine tests done on time. And then in terms of result utilization, only 78% of all clients that had a high valid result were being routinely enrolled for intensive adherence counseling. So from the quality challenge that I just shared, we had to come up with an aim. So this is not, when I say we, I don't mean us as a central office, but these are code improvement teams from the 4 participating facilities that came together to agree on a common quality aim statement that they were supposed to chase in these 6 months. So the aim statement was to improve routine value testing for eligible ART clients and enroll into intensive adherence counseling all clients with high value results in the 4 high volume sites in Balaka. And by so doing, we are seeking to increase routine value testing from 61% to 90% by the end of the 6 months period, which was ending in August, and then improve value result utilization by increasing enrollment into intensive adherence counseling from 78, which was the baseline, to 95%. This was meant to benefit both the stable and the unstable. So the stable for the routine test, and then the unstable for those that had a high result and requiring enrollment in EAC. We had process indicators, outcome indicators, and balancing indicators, which were to help us measure our process along the way. So, for example, the process indicators for this project were to look at proportion of ART clients that are being categorized as stable and eligible for a test on a monthly basis. So from every clinic day, people were supposed to populate something that would tell them to say, we saw 90 people, and of the 90, 80 were actually deemed eligible for a test, and of those, how many got a test on that day. Another process indicator was on proportion of clients that have been categorized as unstable by virtue of having a high valid result, and how many of those are actually being enrolled in EAC. Then we had other supporting process indicators trying to measure how people are committed to this whole thing. So, for example, we're looking at a number of site level core improvement team meetings, which were held at facility level in each month. And then how many were the learning sessions that these core improvement teams participated in on a monthly basis. Again, for the coordination team at the district, they were responsible for mentorship activities, so traveling on a monthly basis to these participating 4 peripheral facilities to mentor them, make sure they are still on track with whatever they were aiming to achieve. So as part of the process indicators, we also had it listed to say how many hands-on mentorship visits were conducted in each month. On outcome indicators, we were looking at proportion of variety clients with at least one test done. So this was what we were supposed to at least look at the end of the project and see if indeed our aim has been achieved or not. Once again, when I say I or I say we, I mean the teams in the participating facilities. The other outcome indicator was on proportion of variety clients with high valid results that have been enrolled in EAC, and how many of those that have been enrolled in EAC have completed their 3 sessions. And of those that have completed the 3 sessions of EAC, how many have been offered a second test, and then the result is known. We also had balancing indicators, which were supposed to provide checks and balances, just to give us a true picture at the end of the project, to say if at all some areas were hard to achieve, what were the issues behind. So for example, one balancing indicator was on number of so-called days for DBS bundles. This was a clinic-based indicator. So clinics of DBS bundles, which are supposed to be used to collect samples for viral load. And we were supposed to be checking, was there any day in each month when facilities had stockouts of these DBS bundles, therefore they were unable to offer any tests for viral load. Number 2 balancing indicator was on the side of the lab, since it's a lab clinical interface team. So we are looking at were there any days in each particular month when the molecular lab was had a system downtime, meaning to say no tests were run. That was supposed to be an indicator of interest at the end of everything. Going beyond the indicators, now I want to share with you what we have listed at the end, or maybe how the journey fared. So this is a sample of one of the run charts that each facility had. So every facility was provided with a run chart for each of the 2 aims. So remember, there was an aim to do with testing, trying to move it from 61 to 90% by the end of the 6 months project. And then we had the other on result utilization, which was specifically to target clients with a high result and seeing how many are being enrolled in intensive adherence counseling. So each facility had this kind of run chart, and on a weekly basis, they were supposed to be populating data and analyzing it by also updating their run charts. So as we can see from the shared slide, we have a run chart which is well annotated, telling the stories of what were the issues behind the spikes or maybe the dips. But on a weekly basis, every facility was actually expected to kind of a run chart. Now to share with you the actual process. So how did the facilities fare in this journey? So what was supposed to happen was for the quality improvement teams in each facility to meet on a weekly basis, look at data from the clinic days of that week, and then populate it in the reporting forms and be able to analyze, plus also update their run charts. We are on close contact with a mentor, which we had identified special for this facility with support of URC. So we had a mentor who was housed at the center point, which is the district health office, but he was responsible for making contact with all these participating facilities and getting to support them if at all they had any maybe kinds of issues like results that are supposed to be followed up at the lab. So he was more like a link between the facility and the labs routinely. And then the teams, again, were supposed to be sending reports to this district person on their weekly performance. And I must say that all the PDSA, the plan, do, study, act cycles that teams could come up with after devising suggested solutions, which are calling change ideas, were supposed to be for a duration of 1 month. So by the time that we are summoning them for another learning session, it means the PDSA cycle was coming to an end. They're supposed to evaluate and then see what to adapt, what to adopt, and what to abandon. The district team I mentioned at some point to say it was responsible for coordination, and one of the activities in coordination was for them to be moving from the district to the 4 participating peripheral facilities. So this district team was a composition of clinical and lab staff. So all issues to do with results from the lab could be taken care of during these mentor sessions. All issues to do with competence in terms of making clinical decisions could also be taken care of through this team when they are visiting the participating facilities. And then on a monthly basis, I mentioned already that we were meeting all the teams at the central point, which we are calling a learning session, where teams could share their lessons, share their progress, and then even learn from others. If at all they are lagging behind and their issues, they can learn from their fellow participating facilities. Moving on, this is just a slide that shares how a learning session conduct. So we see a provider from one of the participating facilities telling a story of how they had fared with the PDSA cycles which they were chasing in that particular month. This is just a small section of a big team, probably 30 or 40 people meeting on a monthly basis at the central point as a learning session. So after sharing with you the process, here are the results. So at the end of 6 months, this is one run chart on the first aim on results. On improving routine testing from 61% to 90% by the end of a 6 months period. So this is a consolidation of performances from the 4 facilities, and it shares how they had fared. So what is very interesting is to note how they were able to beat the goal of 90% by the end of, by mid-next month 2. And after achieving this great achievement, they were able to sustain those gains up to the end of the 6 months project. Quite interesting. On the other aim to do with improving EAC enrollment for clients with high results, which was at a baseline of 78 at the start of the project and was aimed to get to 95 by the end of the 6 month project. This run chart again shares a story of one of the participating facilities, PHIMBI. Actually, PHIMBI was the star performer. I must admit that our harvest on the side of result utilization wasn't rosy in all the 4 facilities. So an aggregate of all wasn't as the one we've seen on testing. But PHIMBI is one of the facilities which performed exceedingly very well, surpassing all the other participating 3 facilities. So they were able to address issues of EAC enrollment for all their high value clients as early as by the end of week 1 after the rollout of this project. And they maintained that good performance throughout the 6 month period. Quite interesting again. So as I'm getting to the close of the presentation, so what's the story that we harvested in these 4 facilities with the use of a code improvement approach to improve issues around value monitoring by actually bringing together people from the lab and people from the clinic. So there was a significantly a statistically significant shift achieved by all the participating facilities by month 4 of the project. And this basically signaled a departure from old practices, which were putting them at 61% across as an average, to a better way of doing things to even be able to achieve more than what they had aimed, which was 90. But we saw in the consolidated run charts that they had gone up to 100 for offering routine testing for all clients that are eligible for viral load. The other interpretation that we can share from this project is that facilities were able to demonstrate an ability to do things better with their available means. So all what we're seeing here, for those that are very much aware with code improvement approaches, code improvement doesn't bring in resources. It only tries to share, to make people to realize their present performance and see if they are willing to move, if at all there are gaps in their present performance. And then themselves, they start to devise ways to move from their training performances to where they may wish to go to. So that we also found to be very interesting to say people were able to actually demonstrate an ability to do things better without external resources. This slide and the next one is a comparison of the successful change ideas which brought about the success story that we saw in the 2 run charts. So facilities were now screening clients routinely. When people show up at the clinic for their routine drug refill visit, there was somebody who was responsible for screening every client before they get to meet their provider. Like before they get to meet the nurse or the clinician, somebody could do some preliminary work right at the waiting area by going through patient records for each of the patients that is there in the waiting area to check if they have had a viral test done and if they are due for their next one today. So this was one great reason which made facilities to be able to achieve the greater percentages that we saw on the run charts. Number two, the issue of data reviews. So the code improvement teams were now able to meet very frequently to look at their data. It was as simple as reviewing how they have performed or on a weekly basis, like just consolidating just trying to get a picture of what their weekly clinics were made of. So they could tell to say, okay, we are doing fine in terms of testing, we're not doing fine in terms of screening clients. In the end, this kind of data reviews are what contributed to them achieving the results. And then there was another thing. Facilities were now able to devise a system to be able to flag clients' cards to say this client has a high valid result and they have to be enrolled in intensive adherence counseling by just use of a colored sticker. And these are stickers that were not provided by us. It was actually people themselves just finding ways to do things better by coming up with an idea of using colored stickers. The other thing, facilities were now able to share tasks very, very well by coming up with a better way of saying who does what. And this also helped them a lot to achieve whatever they achieved. And facilities were also now using a new way of tracking clients that have a high valid result from the lab to be able to bring them back as soon as possible to the clinic and have them enrolled in intensive adherence counseling. The other successful change idea that we saw was that there was now a better linkage between the molecular lab where testing is happening and the clinic. And people were able to understand and learn the reasons behind and then be able to talk around it and have new ideas suggested to be able to improve any kind of delays. This was, again, a winner in this project. This slide is a slide that shares what was happening in the waiting area, as I was saying, with clients that are eligible for a test. So we see an emoji sticker here, a smiling face, pasted on a client MasterCard. So this is a MasterCard that is retrieved from the storage area onto the hands of the client on a clinic day when clients show up at the clinic. So the person who does the screening was responsible for pasting this sticker on each patient's MasterCard to help the person remind their provider to say, Doc, before you get done with me by just giving me my drugs today, remember, I also need a valid test today. So this is one thing, as I mentioned, that came up as an idea devised by people themselves and not anyone else giving them suggestions on how to do their work. In conclusion, so what happened at the end of the 6 months project after we had harvested these successful change ideas from the 6 months journey? We saw that, well, a code improvement approach had achieved great gains in terms of improving our valid monitoring program in these 4 participating facilities. Therefore, we had to take the same story and share it to non-participating facilities in this district of Balaka. And we've done that again by producing a change package that has listed all the successful change ideas. And this change package has been disseminated beyond the Balaka district. And as we speak, we've been working on an SOP, a standard operating procedures booklet for providers in Malawi that should support them to be making better decisions around valid monitoring. And we've actually incorporated the best change ideas produced results in Balaka into this national SOP booklet. And interestingly, we've also engaged the CSOs. So remember, CSOs have a means of working with grassroots structures of PHIV networks. So we are counting on them to actually make an impact in generating more demand for viral load. So the providers, yes, should be pushing about viral load to their people on every clinic day. But we think through the grassroots networks of PHIVs, CSOs can work with us to give the message to the people so that when they show up at the clinic, everyone who is on ART should be knowledgeable to say, at some point, I'm eligible for a test just to tell if I'm doing fine on treatment or not. And if a provider doesn't bring up this talk about testing, then a recipient of care or a client should actually bring up this discussion, because they have been made well aware of it way before they showed up at the clinic. And I must mention that we have a department in the Ministry of Health which is responsible for it. And we've worked with them trying to put together a change package and make sure these successful change ideas are scaled up across the country to all the other facilities where ART is being provided in Malawi. Lastly, I just want to acknowledge all the players that were part of this great initiative. So the district health office in Balaka, where the project happened, Baylor College of Medicine, which happens to be the PEPFAR implementing partner responsible for HIV services in this particular district of Balaka, and then URC Malawi Lab Project. They were responsible for bits of funding where we're supposed to travel and maybe meet people at their sites of work. Then I must also acknowledge CONTINUUM. CONTINUUM is a collaborative learning network of a couple of countries that is working around improving adoption of differentiated service delivery models by countries in Africa. And they were the ones that funded our training in code improvement as a central office responsible for HIV. And then from the knowledge that we received from this training, that's why we're able to pilot a project on code improvement in Balaka. And lastly, the testing lab, which is manned by Balaka, which is manned by DREAM in Balaka. Thank you.
Together with the, thank you very much, Brown, together with the Malawi team for that, the sharing of your experience through the project that you undertook. I know the people out there in the audience have been following closely. And as always, we usually put our questions in the chat. Also a reminder, if you have not yet registered, please register still in the chat. We have over 52 connections, but we want to know the people behind these connections. If you are more than one, indicate all the people that are within that, at that station where you're connecting from. Otherwise, I will open up the session now to the audience to react in form of questions or seeking clarifications or adding something if you feel like, especially from the Malawi team, that something did not come out very well. So Nicholas, I think you've been monitoring our chat. Can you help us know the questions that are there?
Thank you very much, Dr. Charles, and thanks, Dr. Brown, for the wonderful presentation. The first question is from Swede, and she is asking, what was the rationale of using dried blood spots versus just plasma for viral testing, I think in Balaka district? Once again, what was the rationale of using DBS versus just plasma for viral testing in the area where the QI project took place?
Dr. Nwas, I see a couple of questions in the chat box. Would you want me to take one by one as you?
Maybe you could read like 2 or 3, and then he answers. Can you read another 1 or 2 so that Nicholas?
Okay. The other question from Collins Odiambo is, what were the underlying issues at baseline for low uptake of viral tests and intensive adherence counseling? Once again, what were the underlying issues at baseline? What were the underlying issues at baseline for low uptake of viral tests and intensive adherence counseling? You can first answer those.
Thank you. So the first question is on what was the rationale for using DBS and not plasma. I must mention that as a country, Malawi, we had to migrate to using more of plasma specimens. So it's like our primary policy for viral testing in country is use of DBS. So maybe I know as a person who had this question probably was also interested to know why DBS and not plasma, because I mentioned that I have a molecular lab in within the district in Balaka. But I must say we have few facilities that are using plasma, and a lot more facilities are using DBS. So this year we are actually doing a bit of migration to embrace more of plasma samples, but there was a lot of preliminary work that was supposed to be taken care of. So as we speak, I think 98, if not 93 of our samples are DBS. The other question was on what were the underlying issues at this time, uptake of viral load test, and even for low intensive adherence counselling. Wow. As I displayed when I was talking about the quality challenge, these are things that people never had time to look at. So what they thought was, we are doing fine. We know what to do. We are testing every person, but they had no time to be looking at data. So one aspect of their work which got improved with this project was to help them to start looking at data. So I must say there were any special issues, and I mean behind the underperformance. Aside that, people were just working routinely, business as usual, without actually looking at their data and being able to know if they had shortfalls. So by the time we had this baseline assessment done, and then the results came out like that, we were all startled because they thought all along they were doing the best thing, not knowing that they were leaving out quite a substantial of their clients without being tested.
Okay, thank you very much. Cedric is asking, what was the key reason behind patients failing therapy to 75%, and what did you do to mitigate the challenge within 6 months? I think he made a low uptake of viral load. Once again, what was the reason behind the low uptake of viral load, and what did you do to mitigate the challenge within 6 months mentioned? Yes, Brown. Dr. Brown, you are muted.
Sorry for that. So thank you, Dr. Nicholas. My response will be almost similar to what I just said, or as to what were the reasons behind patients failing facilities failing to get to the desired levels. So as I mentioned, we just found out that people were not looking at their data, so they never knew to say we were lagging behind in terms of performance. And then this other question on what was the key reason behind patients failing therapy to 78%. So the 78% is EAG enrollment, not failing on first line, but only 70% of clients with a high result of viral load were being enrolled in EAG instead of the ideal 100%. What did we do to mitigate the challenges in the 6 months period? So it's the issues that are shared in the successful change ideas, the success interventions. So things like just being able to have a tracing system for every result from the lab that is received as being high, above 1,000 copies. There was somebody now who was summoned from the facility to do tracing. So they get to bring the client from wherever they are to come back and enroll in intensive adherence counseling. I see another question here. I don't know if Dr. Nicholas, you also read this. Maybe let me read
I'm just going to read that one. Yeah, it's from Collins Odiambo about the balance indicators that you talked about. What did the data on DBS shortage and testing downtime look like over this period? Once again, what did the data on the DBS shortage and testing downtime look like over this period?
Thank you. So it's kind of funny, but this is the reality. In the 6 months that we worked in Balaka, we never had a single day where facilities had a stock out of the DBS bundles, so they couldn't test. And again, we didn't have a single day of system downtime at the lab, not even issues of reagents, issues of HR. The 6 months elapsed without a single day of such kind of a report coming either from the lab or the clinics. So it's kind of funny, but that was our experience.
Okay, thank you very much. The other question from Kabuje from Tanzania, he is asking, which reporting tools did you use to collect data for unstable clients enrolled on intensive adherence counseling and completed ISC to national level? Once again, which reporting tools did you use to collect data for unstable patients enrolled on ISC and completed it to national level, stroke central level?
So thank you once again. Let me start by saying the question is leaning on two ends. So we had reporting tools special for this QI initiative, which were being used by the facility staff for them to be able to have, to collect data and have it analyzed and update their run charts. The same was also being shared to the district coordination team on a weekly basis. So we had devised simple reporting forms for them to be using. But the other end where the question is leaning on, where it's mentioning national level. So there is again such kind of an activity. So we have a reporting tool that the national program has to capture data for clients enrolling in EAC, those completing EAC, and how many actually getting a second test and even being switched to a better regimen if they are deemed to be failing or confirmed to be failing. So there are tools for the national program. They are available even for sharing. And then we had tools special for this project, and both are available for sharing.
Okay, thank you very much. I think you will share those and we share with the community. Then the other question from Natasha from Southeast, she's asking what was included in the change package that you talked about? What was included in the change package that you talked about?
Okay, so thanks, Natasha. The change package that I mentioned, is a compilation of all the successful change ideas, or maybe the things that made the facilities to get to achieve the performance that I just shared. So it's a compilation of the successful solutions which they had tested and then adopted, and it's now part of their routines as they are continuing with their daily work.
Okay, thank you. The other question from Dr. Chais is, what are the 2 to 3 inputs that you think were responsible for the results you saw? The 2 to 3 inputs that you think were responsible for the results that you saw.
Thank you, Dr. Charles. So if I was to only highlight 3 key inputs that made this initiative to be a success, I will first of all mention of buy-in from multiple stakeholders. So it was a project that brought every stakeholder who is working around HIV care treatment issues in the district on the table. So it wasn't a project that was owned by one stakeholder or maybe one office. It was all players brought on the table. So my sectoral approach has to be on top of doing a code improvement project. Because remember, as I mentioned, we have partners, paid for partners that are working in the district. They have mentors supporting these facilities that we are working with. And then they also had to carry the same message that the district health office using this code improvement initiative were carrying on their routine mentoring activities. So that's one. Number 2 input, I would mention of having persons that should anchor the whole activity. So this is a project that was fully owned by the district health office, a government arm that doesn't so much have a lot of resources. But what they were able to do in the first place was to allocate a person to be a linkage between the participating facilities and the coordination team plus the testing hub. So this person was a hub of everything to do with the activities of this project. And maybe the 3rd input that I must mention was the support that we got from URC. So they were able to support coordination activities, for example, simple allowances of airtime, fuel for the coordination team to go and mentor as the participating facilities, even for the focal person of the district, for him to be able to call and get reports from the facilities. So these were the key inputs that made this project a success.
Okay, thank you very much. The other question from Pam from Abbott is there a plan in place to ensure continuous monitoring of site performance to ensure that clinics maintain their new great performance? Once again, is there a plan in place to ensure continuous monitoring of site performance to ensure that clinics maintain their new great performance?
Thank you, Dr. Nicholas. So that's a very interesting question and very, very relevant to be addressed. It's always important to, as I mentioned, maybe let me just take it back. As I mentioned, I know most of you could be aware that code improvement is always about moving people from maybe a business to get to support them to know their shortfalls and use their own available means to work around coming up with a new culture of doing things. So a culture shift is what is always aimed in code improvement. We believe by not bringing in extra external resources in this project was one way to make sure the performance that would have been achieved by the end should be sustained. And we've recently been working around making a follow-up project just to appreciate if indeed the gains that were achieved in the 6 months have been sustained. But there has been a way since the end of the project up to now, how we've been able to go back and review the data from these participating facilities through the routine program data that we collect on a quarterly basis. And I also pointed to Dr. Charles that I should be sharing that through Slack or the other platforms that we interact as LabCoP, just for the people to appreciate if the gains have been sustained so far.
Okay, thank you very much. The other question from Dr. Chais is, how scalable is this strategy and what is happening in Malawi ever since this intervention? Once again, how scalable is this strategy and what is happening in Malawi ever since this intervention?
Thank you once again. So, well, as Malawi, we think this is scalable and we've already taken strides to scale it up. As I mentioned already, we've started to work with the Quality Improvement Directorate in the Ministry of Health to have this approach scaled up across the country. And as I speak, we are now collaborating with them. We have a document in draft form, which we are calling HIV Services Quality Improvement Framework. This is something that wasn't there before. But with the lessons that we have harvested from this project, we are very much encouraged to say, I think it's possible to achieve great gains using quality improvement approach. And we would want to see that happening beyond Balaka district. So that's our next plan of action.
Okay, thank you very much. The other question from Kingston, Omo Emmanuel from Nigeria, he is asking which viral equipment platforms are in use in Malawi? Please share the tools used with all. Once again, which viral equipment platforms are in use in Malawi? Please share the tools used with all.
Thank you. So we are a couple of us on the call. The other colleagues may come in, but we have Abbott. So we're using Abbott M2000. We have Horogic Panther this time around. We have Roche CapCTM. So those are basically the platforms that we are using for viral testing in Malawi. And we are going to share all the tools that we had used in this project, which we think could support you to also do a similar project wherever. Thank you.
Okay, thank you very much. Then Collins is asking, do you have any comment on return of results to the patients and the turnaround time? Do you have any comments on the return of results to the patients and the turnaround time?
Thank you. So our current total turnaround time for viral loads isn't that best. So we are now talking of an average of 14 to 21 days. But what we've listed in our policy documents is to ideally take it down something like a maximum of 10 days. And this, work has started to happen around realizing this. So, for example, there has been some work so far around hub automation, trying to take out some of the duplicated activities that we had in the cascade, from testing to even return of results. That's just one thing. And specifically to answer on the return of results to clients, what is happening currently, so results, most of the results are actually paper-based. So it's printed at the lab and then sent to the hubs, and then it trickles down through riders for health couriers to get to the providers on the ground. But this year, again, 2019, we are studying a new approach. So we want to make use of SMS platform. So for providers, they should be able to access results through their phone call, through their phone handsets. And for clients, they should be able to access the same by just getting a signal of a simple SMS on their phone for those that have phones to say, you are required to go back to the facility. There is something important for you there. So far, that is happening. Thank you.
Okay, thank you. If anyone from Malawi wants to comment on what Dr. Brown is saying, feel free to do so. Then Kingston Omo from Nigeria is commenting and saying, please share the HIV services quality improvement framework. Then Ngairo from Tanzania is saying, in many places, the problem facing viral load data is delay of entering viral load results in CTC2 and CTC3, hence affecting viral load testing coverage data. How is this in Malawi? Once again, in many places, the problem facing viral load data is delay of entering viral load results in CTC2 and CTC3, hence affecting viral load testing coverage data. How is this in Malawi? And the last one from Emmanuel, you answer them at the same time. How many spots are stroke were used for DBS for viral load using Abbott platforms? How many spots are stroke were used for DBS for viral load testing using Abbott platforms?
All right, thank you. So starting with the brother who wants to know how entering of results, specifically high viral results at clinic level, is happening in Malawi. So as I mentioned, results are taken to the facilities through riders for health couriers as they are going around in their sample transport routines. What happens when the facilities get results? They are supposed to update their facility registers. So we have a register special for high viral load at every clinic, and they're supposed to update the registers for all results received as high. Even for the suppressed results, there's also a register to capture those. So it's the task of the facility staff to actually update this. But you are right. So there have been instances where at times of reporting, the reports may show as if facilities are not doing very fine in terms of viral load monitoring, maybe on the side of taking action on clients that have high results. But when you go back, you only find that they were able to get results. What was remaining was for them to update the tools on the ground. So update the registers and then generate a better report from the registers when the registers have been updated. So at some point I mentioned to say we have another document, National Viral Load SOPs providers, which we are finalizing as we speak because it's earmarked to be launched in October. It's a simple, handy reference material meant to support providers on the ground with competences in how they can be able to take action on every bit of the cascade, even to do with what happens when results are received at city level. So this should support the facilities to actually do better. But as we speak, mentorship is always ongoing to be able to capacitate the people on the ground with skills in how they can put their M&A tools up to date so the reports generated should actually reflect the truth of how things are faring. The other question on how many spots are used for DBS for viral load on Abbott platforms. Wow, I must need a clinical guy. We have a lab team, lab colleagues on the team, but to the best of my knowledge, I think we are using one. So we collect 5 spots on each DBS card, but I think it's 1 spot that is used on the Abbott platforms. If I'm not right, I think one of the colleagues may come in. Thank you.
And the Malawi team, I think your lessons are really very clear, and it was a handed project that was not rocket science to do, and doesn't need lots of resources, but was able to have such very impactful outcomes. So the encouragement is that we can do the same in our setting. And when you highlighted the key inputs, including bringing everybody on board, having regular meetings and support to sites, and a few logistical and coordination work that was done. These are part of our routine things that we do, but we don't do them vigorously. So I think it is all about focusing our efforts towards systems and fleshing out challenges around how to get results coming into the facilities and relaying the results to the patients and using the results to decide what to do with the patients. Thank you very much, Malawi team, for sharing your experience. I know time is not enough for us to exhaust all the questions, but since we have a WhatsApp group, the questions should continue to flow. And the Malawi team, you should be ready to continue answering questions. Those we have not answered on the chat, I will ask Nicholas to push them onto the WhatsApp group, and then the discussion continues. And the rest of you have also done similar projects, and you have something to add or some information to share, you are still welcome on the WhatsApp group to share your experiences on how to set up systems that improve the lab clinic interface and also the utilization of results for patient care. So I just have a few announcements, and time is not on our side. First and foremost, you know, we are organizing a face-to-face meeting. You usually have this annual event, and this is happening in October from the 22nd to the 24th. It will be in Addis Ababa at our headquarters. And I know you have already received invitation letters, and about 5 or so country team members have been invited to come to the event. If you haven't had anything, probably you check with your lead team lead for information. Otherwise, as you're coming, before you come, please look at your action plans. You remember when we had our first face-to-face meeting last year in Kampala, we developed action plans, and we've been working with the country teams to ensure our action plans fit into our funding frameworks and so on. We would want to have an update during this face-to-face meeting on what is happening with the action plans, how far you have gone in terms of implementing some of those actions that you highlighted are going to be implemented. We will need to have an update on that. So please make sure you have all that information arranged as the country teams are coming. Another thing, we sent you the assessment tool, the viral load assessment tool, for you to assess your viral load program as a way for us to compare what it was last year and what it is this time around. But still, a few of us, or a couple of us, did not fill this assessment tool completely. We still see gaps in the assessment tool, and we are going to be reaching out to you, asking you to actually help us fill the information that remained unfilled. And if there is any reason as to why it can't be filled, you you help us to put it in the comment section why such information cannot be got. That could also be helpful for us as we discuss strengthening of our M&E systems and supporting countries. We are going to have a very strong focus around engagement of civil society during this meeting, how civil societies can be handy and can be used to generate demand for viral load and even for result utilization. So we asked countries to come up with a hashtag. You develop a hashtag that can be used for generating awareness and creating a lot of momentum and awareness for viral load monitoring. So I think you've been already approached. We expect your hashtag to be sent to the communication officer within ASLM. If your country team has not done that already, please do. We need these hashtags. We are going to be evaluating the hashtags during the face-to-face meeting, and we'll pick out one which is a winning one that all of us will ride behind and generate a lot of demand for viral load moving forward. So I would, I know time is already gone. I wonder whether there is there's an Dr. Pasco. I think you are not, I don't know, is there anything you want to say? I want to dismiss or to close the meeting because it's already time. So if there is nothing else to communicate, we will be passing the next timeline or the next activities, like our next assessment, our next session. We'll be giving you information in the course of time. But for now, let all our energies be planning for the face-to-face meeting. Make sure you have information about your action plans. Make sure your viral load assessment. You did the assessment, but also look at your assessment results and try to make sense of it. We are doing an assessment on our end, but we want to also, as a country team, to look at these results and try to make sense of it. And when we will be sharing our analysis, it will be good for you to see whether you are analyzing it the same way we did, and if there are any differences, you can ask questions why we are getting different results from what you're getting. But it will give you more interest or more insight into your data and what sense to make out of this data. Look at your results and try to make sense of it. And if we reach out to you to complete whatever is not completed, please turn back to us urgently, because as we try to do the assessment, we see gaps that cannot help us answer or completely do the analysis. And regarding the hashtag, reach out to the community officer, who is our community officer, who is reaching out to you already for you to push your hashtag back to us. Thank you very much. I wish you the rest of the week and the month. Looking forward to meet you in Addis Ababa next month. Have a good time.
Thank you.
Bye-bye. Thank you. Bye.